Hello, everyone. And today we're going to be having a short mock test for your upcoming respiratory pathophysiology seminar. And we'll explain the questions as they go. Don't worry if you get stuff wrong, it's fine. You're still learning, it's okay. And if you have any doubts, obviously you can reach out to any of us. So I'm going to start the quiz now.
Okay, so for this question, can you guys hear me?
Yes.
Okay, so for this question, the first option, well, all of this is about pulmonary hypertension, can be induced by sympathetic activation. Yes, this is true. Usually, sympathetic activation causes vasoconstriction of the vessels, and this also applies for the pulmonary vessels. And in the scripta, there is some notes about how certain drugs, for example, methamphetamine and cocaine, causes sympathetic activation, and that will cause the vasoconstriction and cause pulmonary hypertension. So the first one is true. Is caused by Eisenmenger syndrome. So this is also true because if you remember, Eisenmenger syndrome is a left to right shunt of the heart, and because of that will cause a volume overload on the right ventricle. And because of that volume overload, whatever is going to the pulmonary circulation is going to be too much. So there is a reflexive vasoconstriction of the precapillary sphincters to prevent edema formation. And even though it's trying to prevent edemas, it is contributing to an increase in the pressure in the pulmonary system, so it does cause pulmonary hypertension. Then about pulmonary embolism, causes hypertension only due to reflexive precapillary vasoconstriction. So this is false because it's true that it causes hypertension because of the reflexive vasoconstriction, but there's also a decreased blood flow to the areas that are embolized. And because there's a decreased blood flow, there is a reflexive bronchoconstriction according to the V by Q ratio, and that results in hypoxia in that area, so you also end up having hypoxic vasoconstriction. So these two factors both contribute to the hypertension that is caused by pulmonary embolism. Then the next question, cor pulmonale can be caused by pulmonary venous hypertension. So this is false because cor pulmonale is strictly due to respiratory causes or diseases of the pulmonary system, whereas we're talking about the pulmonary venous hypertension or the pulmonary venous sites, which is not true. So can result in pulmonary edema. This is true because if there's hypertension, there is an increased pressure over there or an increased hydrostatic pressure, and that is one of the factors that results in the formation of edema. Okay, so for this one, pulmonary edema can be due to shock and nephrotic syndrome. So shock is generally an inflammatory state. So you have an increased permeability of the capillaries, and that causes the liquid to move out of the vessels and result in the edema formation. Nephrotic syndrome is it's a case of protein loss, and because of that, you have a reduced oncotic pressure, and those are also one of the factors that result in edema formation. So can manifest with inspiratory crackles, coughing up pink frothy sputum, and cyanosis. Yes, this is true because there's a fluid accumulation and you can also cough up this fluid. It might be slightly tinged with blood, which is why it's a pink frothy sputum. And you may also have cyanosis because if there's a case of hypoxia because of the edema, there's a reduced gaseous exchange in the alveoli. So that results in some degree of hypoxia. Cardiogenic etiologies include aortic regurgitation. This is true because any valvular dysfunction can result in pulmonary edemas. Can be due to infections. So this is false because infections usually result in exudates, and exudates have a different composition from edema. It usually has more protein versus edema being more watery and more thin. And the other thing is that infections usually result in exudate that presents as pleural effusion, meaning that it is present within the between the pleurals. But pulmonary edemas refer more specifically to the pulmonary tissue being locked up with water. Okay, so for the first one, for ARDS, key role of the early phase is played by neutrophils and pneumocytes type 1. So the intent of this question is to highlight what are the main cells responsible for the inflammatory state of ARDS. And we know that ARDS is a pro-inflammatory state initially because of the damage that is done, and it is due to neutrophils and pneumocytes type 2. So these two cells are responsible for releasing pro-inflammatory cytokines and then causing further damage and so on. Pneumocytes type 1 are later involved in the case where they become damaged, and because of that, you have fluid accumulation in the alveoli. But otherwise, the key role is performed by the neutrophils and pneumocytes type 2 overacting and releasing pro-inflammatory cytokines and causing further damage. So symptoms may include chest pain, hypotension, and shock. Chest pain should be like typical for hypotension and shock because of the inflammatory state. There is the increased permeability of the vessels, so there's extravasation of fluid, and that can cause hypotension and severe cases even shock. Results in metabolic and respiratory acidosis. This is true because the patient will have hypoxia because of the poor function of the lungs. So you have metabolic acidosis because of the increased anaerobic respiration and the increased lactic acidosis. And because the lungs are not functioning too well, the patient typically cannot breathe very deeply. They have very shallow breathing, so they have more retention of carbon dioxide, and that causes respiratory acidosis. For the artificial ventilation, it mentions here high frequency, high pressure, and high volume. So the high frequency and high pressure is true, but not high volume. The risk of high volume is that you might overinflate the alveoli, and because they're already so weak, they might become damaged and they might rupture. So you opt to use a lower volume, and in return, you have a higher frequency and higher pressure because you're using a low volume of artificial ventilation.
Okay. So over here, the first one, it says pneumonia results in a hypercapnic state causing acute respiratory failure. It's not exactly true because in pneumonia, obviously, like you're going to have impaired gas exchange. And you are also aware that carbon dioxide has a way higher diffusion like coefficient. It has like greater solubility, almost 20 times more than oxygen across barriers. So because of that, what will manifest first is hypoxia. And only if the situation gets bad enough, then it would lead to hypercapnia and then its consequences. So the first thing that would happen is a hypoxic state, and that's why the statement is false. The next one, yes, it is true that myasthenia gravis can result in a hypercapnic state, and this is because as you're all aware, I'm sure myasthenia gravis is an autoimmune condition where you basically have antibodies against the acetylcholine receptor. So what happens because of this is acetylcholine can't bind, and the cascade doesn't ensue, and because of that, you're not able to contract your muscles, and the diaphragm is also a muscle, and it gets affected, and you have respiratory depression. And because of this, since you can't ventilate sufficiently, the carbon dioxide begins to accumulate, and therefore you have a hypercapnic state. And the next question. So restrictive diseases, what they do is you have a decrease in vital capacity. Obstructive diseases are those where you have an airway obstruction, and now you have to work against that. So an increase in work would be something that occurs more so in obstructive diseases. And additionally, in restrictive diseases, you would expect to see hypoxia first, and then maybe if the situation gets bad enough, hypercapnia later. But in obstructive diseases, you do see hypercapnia because you're not able to uh, carry out those normal functions of gas exchange because of the airway obstruction. So I hope it's all clear, and we can go to the next question. Okay, so over here, the first one, obviously not true because hypoxia is going to trigger sympathetic activation, and this in turn is going to cause tachycardia, not bradycardia. The second one, also not true because, as I explained in the previous question, um, hypoxia always occurs first when you have any sort of problems with the process of ventilation or gas exchange, and then later you would have hypercapnia. In fact, I think in Scriptice mentioned that hypercapnia never manifests by itself. It always manifests with hypoxia. So only when situation gets worse, you would have hypercapnia. Then the third question, this is true. CO2 tends to stimulate the respiratory center up to 70 mmHg. And if you go past this point, then a greater increase is going to cause respiratory central depression. And respiratory and metabolic acidosis occur together. That is also true. Respiratory acidosis is because you're not able to ventilate enough, so you're accumulating CO2. And metabolic acidosis is actually a consequence of the hypoxia, which increases lactic acid production. And as a result, you have lactic acidosis. So you can have both of these happening together during respiratory failure. And the fourth one, So circulatory shock does occur in the advanced stages, but it's not a consequence of hypoxia. It's actually because of hypercapnia. So if this said like maybe initial stages, then the statement could have been true because we established that, okay, you have lactic acidosis as a result of hypoxia, which would also cause vasodilation. But over here, severe hypercapnia, it can cause like very large systemic vasodilation, and that puts you in a circulatory shock in advanced stages. So yeah, I hope that's clear. And if there aren't any doubts, we can move to the next question.
All right, so this is a pretty straightforward question. And the first two options, carbon monoxide cyanide poisoning and using hyperbaric oxygen therapy to treat gas gangrenes, it's given as a list of indications for the therapy. It's there in the scripta, and it's just added here to make sure that you guys go through that and understand why is it given. And the third option, it can lead to hypermetropia, middle ear rupture, and lung damage. This is incorrect because it's not hypermetropia, it is myopia. And there's a difference, and I've added this question so that you guys understand that you don't have to brute force memorize everything, but you need to understand why does a hyperbaric oxygen therapy cause myopia and not hypermetropia. It is because when you give high pressure oxygen, the oxidative stress in the lens causes it to absorb water and swell up. This will increase the refractive index and cause myopia, cause the image to form before the retina. So that will lead to myopia. It will not lead to hypermetropia. It it will like never lead to hypermetropia. The last option, like Lucas marked it correctly, it is too much for altitude sickness. For altitude sickness, you're given normal oxygen therapy, normobaric oxygen therapy. Perfect. I think so. I've made this too easy. The first one, obviously, it's for anemic hypoxia. For hypoxia, the definition is just that this drop in PO2 because of altitude or other reasons. And if it is chronic, it can lead to polycythemia by increasing the erythropoietin. The oxygen demands for the body is not being met, and the body produces more erythropoietin so that there's more RBCs to carry more oxygen to the body, enough oxygen for the body. But the problem with polycythemia is that it can cause some perfusion problems because this will increase the viscosity of the blood. So you need to understand with every uh, response of the body to stress, there might be certain conditions that might be harmful for us. So polycythemia can occur when the erythropoietin is produced and the RBCs are increased, and that can lead to hyperviscosity. Normally, it should be fine, it should be maintained properly, but that could also be a scenario where it could lead to some perfusion problems. It will first cause respiratory alkalosis in an acute condition because in hypoxia, you start hyperventilating. Hyperventilating means you're losing more PCO2, and that will lead to respiratory alkalosis when your PCO2 is low. In chronic conditions, what happens is that the tissue is not getting enough oxygen and they will undergo stress, and you will have lactic acidosis because without oxygen, they're trying to metabolize glucose and thus they produce lactose, lactic acid actually. And that's how you will get the metabolic acidosis. That's a chronic complication. Respiratory alkalosis, acute. And yeah, these two questions are just there so that you guys can understand.
Yeah, I think that is all correct. So two circulations of the lung. Wait, I can be heard, right?
Yes, yes.
All right. So the two circulations of the lung, that is the functional and nutritive circulation. It's not high pressure system with low oncotic pressure because that would lead to pulmonary edemas. In fact, the opposite is true. And then the functional circulation is maintained to keep VQ ratio at 0.6 on average. That's incorrect. It should be 0.8. And the anatomic dead space includes, I don't think the third one, sorry, the fourth option should be correct. Okay. And then the fifth option, yeah, it does lead to cor pulmonale, and the reason is because it can lead to pulmonary hypertension, and that would lead to compensation and eventual decompensation by the right ventricle, and that would eventually lead to cor pulmonale. So the first statement is obviously wrong. It's like an opposite principle where there's a principle of physiologic shunting, and it basically increases the blood flow to air-filled alveoli so that there's better gas exchange. Arteries have 0 millimeters of mercury of partial, like carbon dioxide. That's incorrect. It has about 40. The pathologic changes to the capillary, like the alveolo-capillary membrane generally is thickening, so making gaseous exchange more difficult. Thinning would improve gaseous exchange and is impaired by Hamann-Ridge syndrome. Hamann-Ridge syndrome is another way of saying idiopathic pulmonary fibrosis. And what essentially it is that it penultimately causes the thickening of the capillary membrane, like the alveolo-capillary membrane, so it impairs the gaseous exchange.
Do you want me to present the image about the gas exchange right now, or is it fine?
I think it's fine considering they got it correct.
Okay, all right. We can move to the next question then.
Yeah, so this is what the options you guys have selected is correct. Um, Inadequate gas exchange basically leads to dyspnea. That's true. Cyanosis, that's also true. And it also leads to polyglobulia. And the reason why it leads to what polyglobulia is basically increased amount of hemoglobin in the blood. And the reason why inadequate gases exchange leads to polyglobulia is because it's a compensation mechanism by the body where there's hypoxia, and in that case, the body wants compensates by producing more red blood cells in hopes that they would carry more oxygen, if that makes sense. So as a consequence of that, you have increased amount of hemoglobin in the blood, and therefore it leads to polyglobulia. So it doesn't lead to anemia because it doesn't make sense for the body to decrease the amount of hemoglobin, the oxygen carrying molecule, when there is a state of hypoxia. And plethora is a condition where there's like reddening of, for example, the face. This can occur in secondary polycythemia that occurs with inadequate gas exchange, but it usually is a symptom of polycythemia vera, which is malignant, not malignant, neoplastic condition. All right, so these are statements basically questioning your knowledge on cyanosis. So concentration of reduced HB greater than 25 grams per liter. That is in fact the normal amount of that is in fact the normal concentration. In case of cyanosis, there would be reduced HB greater than 50 grams per liter. Central cyanosis affects the skeletal parts of the body. That is wrong because it affects usually like the face, such as the lips, tongue, or mucosa. The peripheral parts are actually affected by peripheral cyanosis, which is in the name. And peripheral cyanosis is caused by congenital right to left shunts, which is incorrect because that causes central cyanosis. It's like a central cause of the cyanosis. Peripheries are warm in central cyanosis, and that is correct because peripheries are not in fact affected in central cyanosis. And because of that, there's proper blood flow to that area, and therefore it's warm. And cyanosis can also occur as a part of Raynaud phenomenon, where there's like, let's just say, periods of vasoconstriction in your hand, more commonly in your hand, and it has a triphasic presentation, out of which one of the phases is cyanosis. More specifically, it causes peripheral cyanosis, not a central cyanosis. So this is about obstructive diseases. It causes prolonged expiration, not inspiration. Idiopathic pulmonary fibrosis is not one of its causes because that causes rather a restrictive disease of the lung. Lymphoma can be one of its causes, and the reason is because, for example, if there's lymphoma of like a thoracic lymph node or a lymph node that's near the vicinity of the airways, what could happen is a lymphadenopathy, basically an enlargement of the lymph node, and that could compress onto the airways, and therefore it would be causing an obstructive disease. Causes coving of the flow volume loops, that is correct, particularly the expiratory part. I mean, we have a graph that I think that I can show. Yeah, that is the one. So as you can see that you're gonna have to take a normal, you're gonna have to take a look at the normal flow volume loop. But in case of an obstructive disease, you can see that during the expiratory part, the person has difficulties expiring the inspired air, right? And therefore there's coving. So it is basically signifying an increased effort in trying to get the air that has been inhaled out of the lung, and therefore it causes coving of the expiratory part. And there is the other thing as well, that it increases residual volume. What residual volume essentially is the amount of air that's left in the lung after the expiration is complete by the person. And in an obstructive disease, the person struggles to get the air out of the lungs, and therefore there is an increased residual volume. And the Tiffanow index, I think, could you go back to the slide? All right. So the Tiffanow index is basically another way of saying the FEV1 by FVC, which is normally 80%, and this is 80% or zero point 0.8, and this is decreased in obstructive diseases, but it stays reasonably the same in restrictive diseases because all parameters decrease by the same or similar extent in restrictive diseases. So for asthma, the more frequent cause is actually allergic, not idiopathic, and it is more commonly seen in children. It does manifest with coughing, wheezing, and dyspnea, and that are like those are the characteristic symptoms of asthma. And the obstruction is usually reversible by bronchodilators, and that is why people who are asthmatic are given these inhalers that contain these bronchodilator medications, so that in case they have some sort of exacerbation, they can use that to get momentary relief. The allergic form is an example of type 1 hypersensitivity, which is true. It's like a classical example. And in case of imbalance, there is an imbalance of the helper T cells, but rather it's not of the, like there isn't more Th1 cells, but actually there's more Th2 cells. And the last option for quick relief is use inhaled corticosteroids. No, for quick relief is actually use like beta 2 agonists. Beta 2? Yeah, beta 2, I think. But basically, rapid acting bronchodilators, not inhaled corticosteroids. Those are rather used in the long term management of allergic asthma. So this question tests your understanding of the chronic changes to the airways in bronchial asthma. It rather causes smooth muscle hypertrophy. Like basically the principle is the chronic changes lead to further narrowing of the bronchi. So the diameter of the bronchi reduces. So anything to basically facilitate the narrowing is what is true. So it doesn't cause smooth muscle atrophy, but rather hypertrophy. Causes epithelial thickening, yes. Deposition in the basement membrane, that is also true. So all those cause narrowing, and it causes rather bronchial hyper responsiveness, or like yeah, it causes hyperreactivity of the bronchi, because in chronic bronchial asthma, what happens is even the slightest stimuli would lead to what stimulation or a reaction by the bronchi. So idiopathic asthma actually commonly occurs in adults over the age of 40. It isn't positive to allergic skin tests because it isn't like the type 1 hypersensitivity isn't involved in its pathogenesis. It doesn't correlate with positive family history, but it does manifest with eosinophilia on a complete blood count. So COPD is like a chronic disease. It's an obstructive disease. That's in the name itself. It comprises of chronic bronchitis, emphysema, and it is mostly caused by smoking. That is true. The I mean, most of the statements are true here. So I guess we can skip to the next question. But one thing about the cor pulmonale is that reason why it leads to cor pulmonale is because of the generalized hypoxia in the lungs, and that causes the vasoconstriction of the precapillary sphincters, and that causes like pulmonary arterial hypertension, and then you understand the pathogenesis itself by compensation and decompensation of the right ventricles. So alpha-1 antitrypsin is basically a protein that prevents the hyperfunctioning of certain proteases that would otherwise digest away at the elastic proteins in the airways. And the elastic proteins are basically responsible for the elasticity in the airways, so ensuring that once they're fully expanded, that they can revert back to their original shape and let the air out of the lungs. So if there's a deficiency in that, it typically causes the hyperfunctioning of these proteases, but these proteases are not collagenases, but rather elastases. It does cause emphysema, particularly of the restrictive type. It also is associated with liver cirrhosis and is more likely to cause the pink puffer morphology of COPD because its pathogenesis more likely involves emphysema than COPD. Sorry, not COPD, chronic bronchitis. So this is some notes that I have gathered regarding the blue bloater and pink puffer. So you guys can take a screenshot of this or just read through it. And yeah, I think that is it. Yeah.
Okay, so I guess this was easy. The key feature, I think we'll just talk about it generally. The key feature of restrictive lung diseases is that there is restriction in the inspiration, so the lung can't actually expand. There is stiffness and fibrosis. The elastic recoil of the lungs work normally, but there's decreased compliance, so decrease in the actual expansion of the lungs and the ability to take in volume. So with restrictive lung diseases, expect to see all the lung volumes to be decreased. Uh, so lung capacity is decreased. Important is decrease in the vital capacity. Tiphonos index, which is the forced expiratory volume over the forced vital capacity, is usually normal or increased because they either decrease proportionally or the forced vital capacity will decrease more than the forced expiratory volume. For it may have an obstructive etiology is correct, especially with the emphysema related to like chronic bronchitis. So I think this is it for this question. We can go on. Okay, so restrictive lung diseases. Localized interstitial process is associated with amiodarone, which is there is an interstitial lung process. There is lung fibrosis that occurs with amiodarone, but it's more diffuse. Local, you would see it in cases of like tuberculosis, bronchitis, abscess, more than actual like medication-induced lung fibrosis. Autoimmune diseases may be the cause of restrictive lung diseases is correct. Autoimmune diseases, systemic lupus, rheumatoid arthritis, even systemic sclerosis, these are associated with chronic inflammation, and with the inflammation, the healing of the lungs with fibrotic tissue and obviously restrictive lung diseases and reduction in the vital capacity. For emphysema is associated with reduction of the alveolar capillary membrane. Usually in the beginning, we consider it more obstructive, but with increased inflammation and the deficiency of alpha-1 antitrypsin, it has more of an restrictive result. For interstitial lung diseases causing cor pulmonale is correct because many of the interstitial lung diseases will eventually cause hypoventilation and hypoxia, and the reaction of the lung to hypoxia is precapillary vasoconstriction, so with pulmonary hypertension. And as Tawhid said, there will be decompensation of the right ventricle and acute right ventricular dilation, also known as cor pulmonale. Okay, so next question. So the general causes of restrictive lung diseases, you can divide them into like extrinsic and intrinsic. Extrinsic is like more of like chest wall and neuromuscular disorders. Not chest wall, chest wall. So like we're talking about scoliosis, obesity, neuromuscular disorder like myasthenia gravis. All of these, they will decrease the lung compliance, decrease the ability of the chest wall to expand, and thus resulting in restrictive lung disease. Alveoli filled with fluid is correct. This includes like pneumonia, pulmonary edema. In general, it decreases the diffusion capacity of the lungs and will therefore result in a restrictive lung disease. Retention of the air with trapping is more obstructive, um, like hallmark of obstructive lung diseases. And increased lung compliance is also more obstructive lung diseases. With restrictive lung diseases, you find normal elastic recoil, so the lung will shrink, and decreased lung compliance. There's increased stiffness and decreased ability of the lung to expand. Yeah, I think for restrictive lung diseases and scripta is explained really well all of the different causes of restrictive lung diseases. Would have taken a long while if we went through all of them. But I think you know each of them separately. It's just you need to understand what is the hallmarks, what are the hallmarks of restrictive lung disease. And if you understand that, I think you will understand all of the other diseases separately, then it's fine. Yeah, I think that's it.